You ever wonder how governments decide which new, expensive drug to fund, or whether to pay for a big public health campaign? I mean, our healthcare needs just keep growing, but the money to pay for it all, well, that's definitely limited. Today, we're going to pull back the curtain on how those incredibly tough choices are really made.
And this, right here, is the heart of the whole problem. We all want the best possible care for everyone, but the cash just isn't infinite. So, a brand new cancer drug comes out and it's super expensive. Do we fund it? What about a nationwide screening program for a totally different disease? These aren't just abstract questions for economists. The answers directly affect the kind of care you and your family can actually get.
So here's our roadmap for this explainer. We're going to start with the core problem, then look at the two main tools people use to try and solve it. But that's where things get really interesting. We're going to uncover the hidden traps inside these tools. Things like, how do you put a price tag on a human life? What's the gap between a perfect lab test and messy real life? And a huge question about fairness that often gets swept under the rug. Let's dive in.
Okay, first up, let's really get our heads around the fundamental challenge here. Why do we even need to talk about value for money when it comes to healthcare?
It honestly just boils down to this one simple fact. With aging populations and amazing but often pricey new treatments, the demand for healthcare is just exploding. Government budgets, though, they're not. And that squeeze forces a really tough question. How do we get the absolute most health for every single dollar we spend?
So, how do decision makers even begin to solve this puzzle? Well, it's not just a guessing game. They actually rely on a couple of key analytical tools to try and bring some hard data to the table.
The two main tools are cost-benefit analysis, or CBA, and cost-effectiveness analysis, CEA. Now here's the key difference. CBA tries to put a dollar value on everything. It asks, is spending $1 million on this vaccine a better use of society's money than, say, building a new bridge? CEA, on the other hand, stays inside the world of healthcare. It's more like, is this new vaccine a better use of our health budget than this other diabetes treatment?
Right. So with the CBA, the goal is pretty straightforward. See if the total dollar value of all the benefits is bigger than the costs. Its real superpower is that it lets governments make those huge, society-wide decisions. It's really asking, where does this $1 do the most good overall? In health, in education, or maybe even in transportation?
CEA takes a totally different route. It asks, for the money we already have set aside for healthcare, which option gives us the biggest health gain? It measures things we can all kind of wrap our heads around, like lives saved or cases of a disease prevented. It's all about getting the most health bang for the healthcare buck.
Okay, now we get to the really juicy stuff. Let's dig into the first hidden trap of these tools, especially the cost-benefit analysis. And it is a big one. How on earth do you put a price tag on someone's health?
I mean, this quote from our source material really says it all. How much is an extra year of life worth in dollars? Or being free from chronic pain? It's just incredibly controversial, and the simple truth is, there's no single right way to do it that everyone agrees on.
So, a policymaker might see a final number from a study that looks like this, 6.0, and they might think, wow, what an amazing return on investment, $6 back for every one we spend. But this is the trap.
Because that's the number one misinterpretation. That 6.0 does not mean the government's about to get a big check in the mail. This isn't like playing the stock market.
So what in the world are these so-called benefits? Well, they're often really abstract concepts. They might include an estimated value of someone being healthy enough to go to work, or some theoretical number for what people might be willing to pay for better health. It's really an attempt to measure overall societal well-being, not actual cash in the government's bank account.
Okay, let's move to our second hidden trap. This one is all about the gap between the perfect, clean world of a scientific study and the messy, complicated reality of our actual lives.
In the health world, the first thing we measure is a treatment's efficacy. This is how it performs under absolutely perfect, ideal conditions. Think of a top-notch clinical trial where patients are hand-picked and monitored like crazy. This tells us if a treatment can work.
But then there's effectiveness. This is what happens when that exact same treatment gets out into the real world. Where patients might forget to take their pills, or they have other health issues, or they live in totally different environments. Effectiveness asks a much more important question. Does the treatment actually work in practice?
And that's the real catch, isn't it?
The amazing results we see from a perfectly controlled trial, the efficacy, don't always carry over into real-world effectiveness. The truth is, just being in a study changes how people behave. So we have to be really careful not to just assume that those perfect lab results are going to happen in our communities.
And this brings us to our third and final trap, which kind of moves from the technical stuff to something deeply ethical. Are these tools, which seem so objective and data-driven, are they actually fair to everybody?
Think about it. When an analysis tells us the most efficient way to spend our money to maximize the total amount of health, we have to stop and ask a follow-up question. Whose health are we maximizing? Is everyone really benefiting equally from that decision?
Our source material points out a really significant limitation here. Cost-effectiveness analyses are usually equity neutral. Now, that might sound harmless, but what it means in practice is actually pretty profound.
So what does equity neutral even mean? Well, it means the analysis only cares about the grand total of health gain, not who actually gets it. So for example, a program might produce a massive overall health benefit, but if it only helps wealthy people and does nothing for, or even harms, the poor, the analysis wouldn't flag that. It's basically blind to fairness, which is a huge problem if one of your goals is to reduce health inequalities.
So, after hearing about all these hidden traps, you might be thinking, should we just throw these tools out? And the answer is absolutely not. The goal is to become smarter, more critical consumers of this information, to use these imperfect but still valuable tools wisely.
This table really sums up the trade-offs nicely. Let's look at CBA. Its big win is comparing health to something totally different, like transportation. But its limitation is massive, that tricky, controversial business of putting a price on life. Then you have CEA. Its advantage is that it completely avoids that problem. But its limitation? It can be totally blind to fairness. Each tool gives you a different, incomplete piece of the puzzle.
So, I'll leave you with this thought. The next time you hear a politician or a news report say a new policy is cost-effective, you'll know what questions to ask. You can ask, is that based on a perfect lab result or messy reality? And you can ask the most important question of all, who benefits from this and who might be getting left behind? These tools don't give us easy answers, but they do help us ask much, much better questions. And asking the right questions, well, that's the first step to making better and fairer choices for all of us.